Welcome everybody. Respiratory Care 440. This is week 2. We're going to talk about the mechanics of ventilation, auto-PEEP, and loops, curves, more ventilator graphics. So we're going to talk first about the primary characteristics of the lungs. And this is the compliance and your resistance. There's two types of forces that oppose inflation of the lung. We have the elastic forces that arise from the elastic properties of the lung and the thorax that oppose inspiration, and our frictional forces that resist, which are caused by the resistance of the tissues, the organs, as they move into place during breathing and resist gas flow into the airways. So compliance. And this is the relative ease at which a structure distends. So in pulmonary physiology, it's used to describe the elastic forces that oppose lung inflation as opposed to those resistant forces. This describes as a change in volume that corresponds to our change in pressure. So if you're a mathematical person, you can look at it as being your delta volume over your delta P. And that is going to give you the ease at which it descends. So how much pressure are you giving the lung unit to how much volume you're getting back in return. So our compliance. Spontaneous breathing patients, total compliance is about 100. It can range anywhere from 50 to 170 based on what you're doing, how your lungs are functioning, if you have any pre-existing airway conditions or lung conditions, or if you're out exercising or sleeping, or depends on what your status is. And when you intubate somebody, compliance can vary, and this is a lot of there's some sexual differences here. So males will be 40 to 50, females will be 35 to 45. And we can actually measure your compliance in a state of no flow. And this is what's considered static compliance. And this is what we learn, or what our ventilators tell us is our static compliance, not just our dynamic. Coming up in a little bit. So monitors changes in compliance is a valuable component in assessing changes in the patient condition during mechanical ventilation. So if we have a compliance that is 100, and we need to calculate the amount of pressure needed to obtain a volume of 500. We just put in your delta V over delta P, and we come up with. So static compliance, this is when it's measured under a condition of no flow. Normal value here is 70 to 100, which would be milliliters per centimeter of water pressure. And it's normally, once you get under 25, that's when you have some real problems with your work of breathing, because it gets hard for these people to overcome this compliance to breathe. So here is just where we would calculate it. So if you look at it in an algebra form, you have your exhaled tidal volume divided by your plateau pressure minus your PEEP, and we plug some volume or some numbers into that. Remember your order operation. So we have 25 centimeters minus 5 centimeters gives you 20 into your 500 milliliters. And what we're left with is 25 milliliters per centimeter of water pressure. The compliant lung characteristics of compliance. So this is changes in conditions of the lungs, the chest wall, or both, that are going to affect the total respiratory system compliance and the pressure required to inflate the lungs. So diseases that reduce the compliance of the lungs are going to be like your ARDS, lung damage, lung disease, and some lung conditions that increase your compliance is going to be emphysema. So this is where, if you have ARDS, these are going to be hard, stiff, they're going to be difficult to inflate. And if you look over here is your normal. And say if this was emphysema, some type of disease like that, the elastic forces over in that B picture are actually damaged, so they're not going to be able to recoil. They're just kind of constantly distended. So these would be overinflated, and that's where you'd have your high compliance, because you're taking a little bit of pressure and getting a lot of volume back. So resistance, these are the frictional forces associated with ventilation that are the result of the anatomical structure of the conducting airways and the tissue viscous resistance of the lungs, tissues, adjacent organs. So mechanical ventilation, resistance to the airway, or your raw, or resistance of airway, is one thing that you're going to evaluate. So it's expressed in centimeters of water pressure per liter per second. Normal patients are 0.6 to 2.4. And as soon as you intubate somebody, just the condition of having endotracheal tube causes their airway resistance to go up significantly. So it goes from that, maybe 1 to 2 to almost as high as 6 just to start. And this is just caused by the artificial airway. And the smaller tube that you use for a patient, the higher the resistance is going to be. So if you have like a infant or a premature baby intubated, the resistance is going to be really high compared to somebody that's got, a garden hose in for an ET tube. And some diseases of the airway can also cause increases in resistance a little bit. So when you look here, again, A is normal, B would be a condition of high airway resistance. And this is where the alveoli doesn't really have anything wrong with it. It's just that small conducting airway. You can see that extra green stuff there. We can say, it's disease, it's mucus, it's whatever, but it's imposing air from entering the alveoli and exiting the alveoli. And with higher resistance, more pressure for breathing goes into the airway, not to the alveoli. And this is a result a smaller volume as gas becomes available. So the time constant we'll show you in the next slides, but this is the time it takes for 63% of passive exhalation or inhalation to occur. So if we're looking at our calculating it, it's just compliance times resistance. So we have somebody with a 0.1 of compliance and 1 of resistance. Their time constant is going to be 0.1. And so in 0.1 second, 63% of volume is going to be inhaling or entering or emptying from the lungs. And after that 0.1 second, you're still going to have 37% left. So you're going to need more than one time constant to completely empty or inflate your lungs. And here we have just an example. If you look on the graph here, the bar that's going up is your inflation and the bar going down is your deflation. So just an inhalation. Here we have at one time constant, you can see that 63.2% has entered the alveoli, but there's still a lot of room for inflation. You get to your second time constant, you're up to 86.5. At 3 time constants, you're 95, and that's where you're really at your peak. And prolonging your inspiratory time is going to ensure that you get adequate delivery of your time volume. And if you look at it, if you're a math person, I'm not really, but theoretically, you could keep going because you see your 95, 98.2, 99.3, 99.8, and then you could go out to decimal points to infinity, but that's not really going to happen in the real world. And you're emptying. This is your downward curve here on the right, where you have one time constant, you still have 36.8% left. 2 constants, still 13.5. At 5, at 3 constants, you still have 5%. So you're going to have to go to 3 to 4 time constants to get a majority of the volume emptying in the lungs. And if you cut them off early, say you stop at 2 constants, you still got a lot of air left in those alveoli. And they're either not going to be fully inflated or they're not going to be fully deflated. Some changes in resistance. This is usually caused by bronchospasm. Anything that can go wrong with your ET tube, say it's too small, it's kinked, it's obstructed for whatever reason, somebody's chewing on it. They also happen when you have a high flow rate, secretion build up in the airways, dampened expiratory flow valves. Maybe you have you're giving some nebulized medication through there and it's causing your valve to stick, water in your HME. And you can look at it on your graphics. And this is where you do your inspiratory hold maneuver. You see your PIP increases, but your plateau stays the same, and there's a big difference between those two values, which is what we went over last week. The flow waveform, you're going to see it just takes your exhalation side of it's going to be really extended, and the volume waveform is it's your expiratory time is just going to be really extended to get to baseline. And we'll talk about loops in a little bit, but how do you fix that? You bronchodilate, you suction, clear water, change your HME, get a bigger ET tube if you're somewhere that likes to do that. Sometimes we have to fight to get it where I'm at, but if they're biting on it, tell them to stop biting on it or throw a bite block in. Change your peak flow or change your exhalation valve filter. What's going to cause some changes in compliance? So we have our decreased compliance. These are where it's going to be harder to ventilate because they have less elastic forces in their lungs. usually ARDS, atelectasis, abdominal problems, distension. They got a big belly that's imposing the forces of inflation, which is interestingly enough going to be next week's topic. CHF, consolidation, fibrosis, hyperinflation, pneumothoraxes, effusions, and increased compliance. This is when you're going to see with your emphysema and surfactant therapy. And surfactant therapy, that's where you're going to be decreasing the surface tension in the alveoli. So you're going to actually change the status of their lungs from a point of decreased compliance to a point of increased compliance. So they're going to go from being hard to ventilate to being easy to ventilate. So that's important for if you're giving somebody surfactant therapy to kind of watch your settings as soon as you put it in there, because you're going to need to decrease it, because all of a sudden, instead of getting 10 milliliters per 1 centimeter water pressure, you're going to be getting 20. So it's just important. And then emphysema. This is where, for whatever reason, the elastic forces of their alveoli are damaged and they're in a chronic hyperinflation status. So in your graphics, you're going to look at your difference between your PIP and your plateau. And this is where you're going to have a small difference. And the loop, it's going to be kind of flat. I'll show you how that looks in the next couple of slides. So auto-PEEP. This is the pressure in the alveoli at the end of exhalation. It's usually greater than atmospheric. Lungs aren't fully deflated before the next breath begins. And it can be caused by disease or mechanical factors. So this is where you have resistance to expiration, early collapse of unstable alveoli using large tidal volume, short expiratory times, or combination. You have three types. You have dynamic hyperinflation with intrinsic expiratory flow limitations. So this is status points like COPD, small airway collapse, dynamic hyperinflation without expiratory flow limitations. And these are usually our fault. This is caused by mechanical ventilation or inappropriate settings. You have too short of an expiratory time, a blocked DT tube, your valves are sticking, they're not opening and closing properly. And three is your exaggerated expiration with activity without dynamic hyperinflation. So this is where your alveoli are okay, but they're actually small airways are floppy. So they force an exhalation that causes, they're forcing so hard that it causes their small airways to collapse, or they have some type of tracheomalacia or condition going on there that causes to be floppy small air. So auto-PEEP, everybody remembers this from school, is you have your VQ matching scale. On the left there you have low VQ matching, normal in the middle, and high on the right there. So once you get to the right there, if you get to your auto-PEEP, that's where you have so much ventilation going on that it becomes excessive and your perfusion is not happening, because it's actually so much that you're collapsing the pulmonary blood flow. So what can it cause? It's not comfortable. It causes an increased work of breathing. They're going to be tachypnic. They're going to be breathing fast because they're ventilating fine, but the pulmonary blood flow exchange isn't really happening. You can actually get to the point where you get hemodynamic compromise, where your lungs are so inflated that it's actually compressing the heart. It can lead to inappropriate treatment, and if it's excessive enough, you can actually cause some alveolar damage where you get your volume trauma. So we can measure it in two ways. First way is static auto-PEEP. That's where you measure it in your sedated and paralyzed patients. And what happens is you occlude the airway, and you're in a state of no flow. That allows pressure to equilibrate throughout the lungs. Sorry, that's a big word. I don't have to use that one too frequently. And once you reach the state of equilibrium, your airway pressures are going to be static. You subtract that from your what your PEEP measurement there is from your external PEEP, and that's going to give you your static PEEP or static auto-PEEP. Dynamic is when you measure it in a spontaneously breathing patient, and it's not really a reliable measure for auto-PEEP in a spontaneously breathing patient. The problems of measuring auto-PEEP is it can frequently lead to underestimations of your true value. And the dynamic auto-PEEP is actually going to reflect the lowest regional auto-PEEP that's going on. So some of these airways that have small airway problems are going to be considered not communicating with that measurement. So we have our hold here in this picture on the right. So we have our top is 5, then we go to 13, 15, and 20. So that 15 and that 20 those resistant forces there, you can see they're actually so significant that those alveoli there aren't going to be participating in the measured PEEP that we have. So when you look at that average, it's actually only going to be the average of the top two alveoli. Those bottom two, well, they're pretty high, and they're just not communicating because they're blocked. Nothing's happening. So while that's giving you a 5, the actual measure is going to be more like 6 or 7, and that's because those, since they're not participating, they're not being averaged into that calculation. Reducing auto-PEEP, you extend your expiratory time. Extend your time constants. Let that volume exit the lungs. You can accomplish that by decreasing your respiratory rate. Maybe you need to decrease your volume a little bit. You could reduce your ventilator demand on the patient, decrease their anxiety, pain, shivering, dead space. So you tell them to relax, they don't. Then you sedate them and paralyze them. That usually works a little bit better. Dead space, if you have extra things in your ventilator circuit that don't really need to be there, take them out. Reduce any type of flow resistance you have going on. Use the largest ET tube that you can. Suction when you need to. Bronchodilate if you need to. And counterbalance your expiratory flow limitations by applying external PEEP. And here's where you just apply external PEEP. So you have on the left there, that one alveoli is a 3. Once you apply PEEP, it's a 5. So you're able to let all of these alveoli communicate with each other and participate in ventilation instead of not really pulling their weight. And this is what's called the waterfall concept of auto-PEEP. So if you look at that top picture, we have our small airways collapsed, and you can see it just needs to get to a point where you just got to stent that small airway open. So the way to look at it is like a waterfall. As you look at this bottom picture here, that bottom airway pressure where you see the waterfall going on, we only need to increase that bottom airway pressure to the point where the waterfall starts. We don't need to go all the way up to alveoli pressure. We just got to get to that critical opening pressure. So once we increase our PEEP to just at that critical opening pressure, then we'll allow to have all these alveoli participate in ventilation. So identifying it on the graphics, this is when you're going to form a pressure waveform. You're going to do an expiratory hold, and you're going to see your waveform all of a sudden go from where your PEEP is or your 0, and it's just going to spike just a little bit and kind of stay elevated, and that's going to be whatever your auto-PEEP level is. Flow waveform is you don't have the expiratory flow go back to baseline before the next breath. Volume, again, volume doesn't get to 0 before the next breath. The loops, basically, they don't meet at baseline or 0 before the next breath. Here you can see it. You have graph A there. You can see the next breath starts before the first breath finishes, so you're going to get some breath stacking and auto-PEEP going on. C is where they fix it. B, here you see it just stacks and stacks and stacks. And D is where they fix it. And same thing over there. And your last one is, you can see, you're not all the way down to 0 before the next breath starts. So extend your expiratory time. Here's some more examples again. Here, the red line on the left there is your normal breath, and you have airway obstruction that leads to hyperinflation there above it. And here we have a loop on the right, a flow volume loop where you have expiratory, or your volume doesn't reach that center of the graph. It's kind of stuck high there, so you're not all the way down to 0 before the next. And there's just one more example. So loops. So we're going to talk pressure volume loops. Here we go. They kind of look like a wimpy football there. So the volume is on your y-axis, pressure on the x. Inspiration is upward, expiration is downward. It goes clockwise, or spontaneous breaths go clockwise, positive pressures go counterclockwise. Bottom of the loop is set at 0 or your PEEP level. And if you draw an imaginary line down the middle, the right represents inspiratory resistance, the left represents expiratory resistance. It's useful mainly for lung overdistension. We're going to show you that in the next couple of slides. You can also show obstructions, response to bronchodilator, respiratory mechanics, work your breathing, leaks trigger, flow. Here we see inspiration on the right going up, expiration on the left going down. The difference between that baseline is your resistance for inspiration and expiration. And at your top there, if you did a hold, that would be your dynamic compliance. So beaking, this is where you get to a point where you're giving a lot of pressure, but you're not getting much volume return, and this is just a state of overdistension. And you can fix this by decreasing the volume. It's basically take away from that peak. So you just have to remember when you're beaking, that means you're giving lots of pressure and not getting any volume back. So you're just overdistending. And here's your another example of somebody with lots of airway resistance. So they went from being that wimpy football looking thing to this fat, just extended loop, and that's just going to have lots of inspiratory and expiratory resistance. This is usually caused by kinked ET tubes or patient biting, or anything in the small airways, but usually that causes it to be anything in your ET tube would be a little bit choppy on here because it causes some interference with your flow. So you have that, and your hysteresis is just your if you had that baseline going straight through the middle there, that's just your difference between your expiratory resistance forces and your inspiratory resistant forces. Here's some changes that compliance can cause on your pressure volume loops. Look here on the left. Here's where you have a state of increased compliance. This is where you're giving little pressure and you're getting a lot of volume back, and you're going to see that in emphysema surfactant therapy. And here, your football fell over. You can cry about it, but this happens in ARDS. This is a state where you have a lot of pressure, but you're not getting a lot of volume. So remember, if it kind of goes upwards and to the left, increased compliance where you're getting lots of volume for little pressure. On the right, it kind of falls over. You get little volume for lots of pressure. Here's an example where basically air goes in, it's coming out, and then it stops. It doesn't get to baseline. So this is where you have some type of a leak going on. Inflection points. So this is where you can calculate. If you look, you draw two lines. You can see that first one kind of comes off the initial slope. Then you notice that a point where the slope changes, where there's 2 points meet, would be your inflection point. And that's, if you think back to your critical opening pressure, right there at that point is that lower inflection point. So that is your critical opening pressure. And a lot of people like to use that when they set their PEEP. So in this situation, maybe a PEEP of 14 or 15 would be appropriate for this patient, because if you go below that, you're going to be seeing some alveolar collapse, and we don't want to collapse because then you get your shear stress or your damaging your alveoli. And this is a poor picture, but if you look, you can see it's a beaking pattern. Again, this is where you can draw an upper inflection point. You don't really want to see an upper inflection point, but if you got one, it's usually because you're overdistending, you're causing that beaking to occur. Sorry, that's a blurry. I couldn't make it any bigger without making it blurry. I'll find it. And flow volume loops. PFT lab, this is your bread and butter. You have flow on your y-axis, volume on your x. Loops are used for the same as your PFT ones. Inspiration is above the horizontal line, expiration is below. Unless you're in the PFT lab, then it's opposite. Your inspiratory curve is going to match whatever your flow pattern is on your ventilator. And the shape of the flow represents passive exhalation. So it's going to be drawn out in patients with low recoil. And it can tell you your peak inspiratory flow rate, peak expiratory flow rate, and volume, tidal volume. But and yeah, spontaneous breaths are just going to. You can assess your air trapping, and this is the big one: is obstruction and resistance. That's why it's used in the pulmonary function lab so frequently. Now you can learn all this other stuff. So here we have, if you follow it around kind of in a clockwise pattern, inspiration starts, you hit a peak volume or peak flow, volume goes up to reach your maximum inspiratory volume. Expiration starts, you get your peak expiratory flow, and then it goes back down to baseline. And that peak expiratory flow is only if the patient's forcefully exhaling and actively exhaling. So this is where you have to coach them to do this. But if they're just on a ventilator, it's not going to be your peak expiratory flow. It's just going to be your expiratory. And here we see our flow patterns match the ventilator. So if you had somebody in the pressure mode on the left there, they had a square waveform, it would look like that. If you had somebody in a decelerating ramp waveform, you can see there, your flow waveform is actually a little bit different. It's actually a decelerating ramp. Again, this is a blurry picture, but it gives you a good example of some of these. So A, the top left would be a spontaneously breathing patient where it just looks like a basketball. It's a circular pattern. B, and again, these are upside down because they're I couldn't find a better picture, and these are just pulmonary function ones. So B is expiratory flow limitation. So you'd see if it was upside down, it would look, just flip it over. You have inspiratory inspiration, expiration. You can see it kind of slopes in, like what we saw last week, where you had a slope on your flow. But instead of being in a flow starvation status, this is where you're having limitations to flow exhalation. So alveoli, there's time where your alveoli are emptying at different time constants. So the volume is going out, but at different rates, and it can be kind of extended. C is the very bottom there. This is where you have an airway obstruction with an inhalation or exhalation. We'll see where it's just kind of dampened. D, which is on the top right, this is airflow limitations with more obstruction. I'm not really sure what I put there, but more obstruction there. E, it's going to be unstable airways. This is where you have your where you can end up with your auto-PEEP without any dynamic problems. So they're forcefully exhaling, cause their small airways to get floppy, and they kind of flop back and forth, and that just causes like your waveform to look kind of choppy. And on the very bottom there, F, the bottom right, would be secretions in the airway. So you have a smooth inhalation pattern, but they exhale, and all of a sudden it's just chop, 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 chop. I mean, you can't really tell much in there. So that's just limitation or airways, secretions in the airway that are causing the waveform to look not smooth. But here's an example of the leak in a flow volume loop. Air goes in, goes out, reaches zero before it reaches the x-axis or your y-axis. I'm sorry. So and here again is a better example of that scooping. This isn't the flow starvation we talked about last week. This is the scooping because you have your alveoli is emptying at different rates, and basically you have that peak where your large airways are emptying, then you have all those small airways that are emptying at different rates, and this is going to cause an extended expiratory time, and it's going to be, it just causes some scooping on your flow waveform.